neurology, ophthalmology, retinal disorders. All right, so next we're on retinal disorders. So what I would recommend you do is take a look at each of the photos for the optic disc and just like what it looks like within the eye for each of these retinal diseases. They like to show a lot of the photos. But I'm going to try to help you out with giving you some hints that can help you get the answer without the photos. But once again, that's only going to take you so far. These retinal disorders are somewhat difficult to understand. So first we have age-related macular degeneration, or AMD, okay? Now, all this is just degeneration of the macula, which is the central area of the retina, right? The central area of the retina, which leads to loss of central vision, okay? And the loss of central vision is known as scotomas, all right? So they will cause scotomas, which is just essentially dots within the central vision, okay? And what happens here is that you have two separate types. You have dry AMD, dry age-related macular degeneration, or wet AMD, all right? Now, dry, what you have to know is that you have a gradual loss in vision due to drusen deposits, okay? So drusen is seen in AMD, which leads to the central scomata, or scotomas, sorry. All right? Very, very important, all right? So that's what you need to know about dry. And for wet, all right, what happens is that you have retinal neovascularization due to increased VEGF, okay? So choroidal neovascularization leads to more blood vessels forming in the eye due to VEGF release, right? Because if you have increased VEGF, that's just something that leads to increase in vascularization. And so you get rapid decrease or rapid loss in vision, okay, due to bleeding from this neovascularization, all right? And that's why they call it wet, because there's blood. And what you're going to see is distortion of straight lines. Okay, that's an early symptom. All right. Now, that's all you really need to know about AMD. So keep in mind, you have central scotomas, you have drusen, all right, which lead to the central scotomas. And then for the wet, you have increase in VEGF, which leads to neovascularization and bleeding. And the first sign is distortion of straight lines. Okay. Next is diabetic retinopathy. Diabetic retinopathy, what did I say? Diabetes is a microvascular issue. So you have microvasculature at the retina, all right? So in diabetes, you're going to have problems with getting blood to the retina, okay? And because of the hyperglycemic state, right? The hyperglycemic state leads to non-enzymatic glycosylation of proteins, which causes clogging of the microvasculature, which leads to a essentially hypoxic state. And in hypoxic states, you have kind of two types of diabetic retinopathy. The first type, which makes sense with the hypoxic state, is the proliferative diabetic retinopathy state. Because of hyperglycemia, you get ischemia, right, or hypoxic state, and that leads to increased production of VEGF. When you have increased production of VEGF, you get neovascularization, and then when you have neovascularization in the eye or the retina, it leads to hemorrhaging and retinal detachment, okay? Very, very important. That's what they talk about for diabetic retinopathy, okay? And kind of overall, I really won't talk too much about the non-proliferative state, but cotton wool spots are going to be seen in the non-proliferative, which is the most common diabetic retinopathy state, okay? And all that really tells you is that there's just some type of damage within the eye, okay? So for patients that have kind of diabetic retinopathy, I would say the key thing to remember is the hyperglycemia leading to a hypoxic state, which leads to increased VEGF production. You get neovascularization in the proliferative state, which leads to hemorrhage and detachment. Okay. On to the next one, hypertensive retinopathy. Remember, hypertensive retinopathy, this is going to be due to secondary chronic hypertension, right? And so you're going to see some type of fibrinoid necrosis of the retinal vessels. Now, they want you to know specifically what like you see on imaging, right? What you see actually in the eye. Okay, so this is an important aspect, right? So you're going to see microaneurysms, so multiple microaneurysms with the eye. You're going to see dot and blot hemorrhages. You're going to see cotton wool spots. Remember, cotton wool spots is just kind of an overall thing that shows like damage. And specifically to hypertensive retinopathy, you're going to see flame-shaped hemorrhages with copper wiring or AV nicking. Like that's very, very important, okay? So once again, microaneurysms, dot and blot hemorrhages or flame-shaped hemorrhages, copper wiring thickened arteries with AV nicking, okay? You have to know all of that. That is hypertensive retinopathy, okay? So keep that in the back of your mind. I will say it one more time. Flame-shaped hemorrhages, copper wiring thickened arteries with AV nicking, microaneurysms, dot and blot or flame hemorrhages, and cotton wool spots, Okay, remember, cotton wool spots is not going to be specific. All right, it's just something that is kind of seen with a lot of these. But everything else that I said here is very important and specific to hypertensive retinopathy, specifically AV nicking and copper wiring with flame-shaped hemorrhages. Okay. Next is retinal artery occlusion. So what they want you to know is that an embolus, okay, essentially just travels to the retinal artery and it causes an occlusion at that area. So you're going to get painless like a monoocular type of vision loss. But just remember that it's just, if you have random acute vision loss in one eye, it can be due to so many different things. So like, that's why I don't really like it that much. But if they're talking about like an embolus that a patient has, like they like to talk about it in association with like severe atherosclerotic disease in like the carotid, because the carotid is the main place that the atherosclerosis or the emboli can form. And that's where it sends the embolus to the retinal artery. So like, keep in mind, that's where it's going to be presenting in association with, okay? Now, what they like to say is that you'll see on fundoscopy a cloudy retina with cherry red spot. Okay, if you see cherry red spot and they're not talking about lysosomal storage diseases, start thinking about retinal artery occlusion. All right, and they want you to know the pathway in which it can travel. So remember, I told you that it's mainly going to be due to carotid atherosclerosis. So let's start with the internal carotid. And so from the internal carotid, it goes into the ophthalmic artery, and from the ophthalmic, it goes right into the retinal artery. Very straightforward. So internal carotid to ophthalmic to retinal, and that's how the embolus travels. All right. Next is going to be retinitis pigmentosa. All right, so retinitis pigmentosa is just progressive degeneration of photoreceptors and retinal pigment epithelium, okay? So you're going to have a typical triad that's seen. You have optic disc pallor. If you see optic disc pallor, that's going to be helpful. If you see retinal vessel attenuation, that's number 2. And the last one is retinal pigmentation with bone spickle-shaped deposits. Take a look at what the bone spickle-shaped deposits look like, because that's actually very, very helpful in recognizing retinitis pigmentosa, all right? The patient's usually going to present with nighttime blindness. Okay, so if you see like nighttime blindness, that's going to be very helpful. But remember the triad of the optic disc pallor, the retinal vessel attenuation with associated pigmentation with the bone spickle-shaped deposits. Remember, nighttime blindness is going to be very key and helpful for this. Okay, next is retinopathy of prematurity. So remember, retinopathy of prematurity can be caused by O2. Okay, so neonatal oxygen. If you give a patient that's premature oxygen, they have an increased risk of retinopathy of prematurity. All right. Because they have like an inability, you get hypoxia of the avascular retina, which leads to increased VEGF, and increased VEGF, once again, causes retinal neovascularization. And I don't know if I made this clear, but the reason we don't want increased VEGF and retinal neovascularization is because all those extra blood vessels that form due to VEGF start to pull and make traction on the retina, and that can cause retinal tears, and it gets in the way of our visual field. All of those extra vessels get in the way of our visual field because they grow in areas where our vision's occurring, okay? It's not specifically at like the optic disc. Okay, so keep that in mind as well. But retinopathy of prematurity is usually going to be due to a neonate receiving O2. And remember, neonate receiving O2, right? What are the 3 high-risk things? It's called RIB, right? RIB. You have R, which is retinopathy of prematurity. You have I, which is intraventricular hemorrhaging, right? And then you have B, which is bronchopulmonary dysplasia. Okay, so keep that in the back of your mind. That's when you give a patient supplemental O2 that's premature and it doesn't really go down too well. Next is papilledema. Papilledema, we already discussed. That's the blurring of the optic disc margins, which is usually caused by increase in intracranial pressure. Okay, and just take a look at what that looks like. It's very straightforward, very easy. Now, for the next 2, for kind of more retinal disorders, you have retinoblastoma. So for retinoblastoma, what you're going to be really looking at is honestly like leukorrhea, and that's all that is just like the whitening with the red reflexes, okay? The whitening of the red reflexes, if you see that in a child, it's usually retinoblastoma, okay? And so that's kind of my hard, fast rule for it. Now, it's caused by mutation to both RB1 tumor suppressor genes on chromosome 13. You have to know that it's both RB1 tumor suppressor genes that are affected in order to cause retinoblastoma. Okay, and then that impedes so RB1 normally impedes G1 to S phase progression. It's kind of just a tumor checker marker, but since you have RB1 tumor suppressor gene malformation or mutation, then you no longer have that checkpoint between G1 and S. Okay, so keep that in mind. It presents with leukorrhea, which is just the whitening of the red reflex. So they don't have a red reflex, they have a white reflex. Okay, and that's highly indicated in a child with retinoblastoma. What they want you to know is that retinoblastoma also leads to an increased risk for osteosarcomas. Okay, very high yield for retinoblastoma and leukorrhea, very high yield to no. They can show you a photo of the kid with the white reflex, and they can say, what's this kid at an increased risk for? And you're going to think, oh, let's go. It's retinoblastoma. That's not going to be an option. Even though it's right, it's not going to be an option. So the answer is going to be osteosarcoma, or they could just say like bone cancer, just to throw you off. Okay. So remember, leukorrhea, which is the white eye reflex, they can show you a photo of it, and it's going to be associated with retinoblastoma, but they can ask a harder question. So it leads to an increased risk of osteosarcoma as well. All right. So overall, that's our retinal disorders. If you have any questions, please sure to reach out. This is kind of a much harder topic than I was expecting, at least when I first started studying for it.